welcome to the ASCO Guidelines podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Mary Ellen Taplin from Dana-Farber Cancer Institute, lead author on Systemic Therapy in Patients with Metastatic Castration-Resistant Prostate Cancer, ASCO Living Guideline version 2026.1. Thank you for being here today, Dr. Taplin.
Thank you, Brittany. It's a pleasure.
And then before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Taplin, who has joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. So then to dive into the content here and what we're here today to talk about. So this living clinical practice guideline for systemic therapy for patients with metastatic castration-resistant prostate cancer is updated on an ongoing basis. So Dr. Taplin, what prompted this latest update to the recommendations?
Thank you, Brittany. Several things prompted the latest update. There's been several phase 3 trials that have been practice changing that have resulted in the last several years that needed to be added to the guidelines to inform clinicians of comprehensive treatment options.
Great, and it's great to have this updated guideline for readers. So I'd like to review the changes to the recommendations in this latest iteration across the patient populations that are outlined in the guideline. So starting with, what are the updated recommendations for patients previously treated with androgen deprivation therapy alone, whose disease has progressed to metastatic castration-resistant prostate cancer?
A nice feature of this guideline is that in addition to the tables, which provide detailed options, is at the end of the guidelines, our readers will find very clear algorithms that describe past treatment scenarios that patients could have had and then outline their treatment options. So it's very clear. Our clinicians will love these algorithms. And one of the changes for the disease state that you mentioned, which is the least treated castration-resistant state of prostate cancer, which is previously treated with ADT alone, is that we recommend testing for mutations in the HRR homologous recombination genes. And the ones that are specifically known and applicable to prostate cancer are the BRCA genes. So there's clear recommendation of testing to remind us as treating physician that now is the time, if it hasn't been done before, to institute both germline and somatic testing. And somatic testing, if it can be done on tissue, is preferable, but if not, the liquid biopsy approaches, the ctDNA approaches, have now advanced to the point that most patients with metastatic prostate cancer will be able to successfully have testing on the liquid biopsies. So that's number one, testing. And then the new treatment options include if a patient does have an HRR gene alteration, and maybe about 20-25% of patients will be in that category, the combinations of an androgen pathway inhibitor and a PARP inhibitor are now treatment options. So for instance, halazoparib and enzalutamide, olaparib and abiraterone, or niraparib and abiraterone are some of the newer treatment options if the patient is HRR positive. So, Brittany, in regard to patients treated with ADT alone, another new treatment option is the combination of radium-223 with enzalutamide. This is data based on the PEACE 3 trial, which did show both an RPFS and OS benefit. For the patient who is HRR negative and has previously not had an ARPI, just ADT alone, the combination of radium and enzalutamide is a new recommendation added to the algorithm.
Great. Thank you for viewing those options for that patient population. And as you mentioned, I think those algorithms are very helpful as figures in the document. They're clear and can be used as at-a-glance tools for clinicians in their busy clinics. So then the next patient population that the guideline addresses, what is new for patients previously treated with androgen deprivation therapy and an androgen receptor pathway inhibitor whose disease has now progressed to metastatic castration-resistant prostate cancer?
Right. So there's several new treatment options. So one is lutetium PSMA 617, the trade name of which is Pluvicto. So that has now been FDA approved to use after progression on an AR pathway inhibitor and prior to the use of docetaxel chemotherapy.
Thank you for reviewing that new option for patients treated with androgen deprivation therapy and an ARPI whose disease has progressed. So then moving into the next set of recommendations, what does the panel now recommend for patients previously treated with androgen deprivation therapy and docetaxel whose disease has progressed to metastatic castration-resistant prostate cancer?
The next group of patients is those treated with ADT and docetaxel, but haven't had an AR pathway inhibitor. Treatment options, again, the HR testing is important. So all patients with metastatic castration-resistant prostate cancer should be considered for both germline and somatic testing. I will repeat that. And if they're BRCA mutation positive, then the option of talazoparib and enzalutamide, olaparib and abiraterone, and niraparib and abiraterone. So the AR pathway inhibitors plus the PARPs. There's 3 choices, so that can be somewhat complicated to think through, but most practitioners will get familiar with one of those combinations and be their go-to. So those are for BRCA positive or HRR positive. The talazoparib enzalutamide trial also included non-BRCA HRR positive gene mutations. And if they're HRR negative, the option that we discussed above of radium and enzalutamide is new to the guideline.
Great. And then the last category of patients that is addressed in this update, what has changed for patients previously treated with androgen deprivation therapy, an androgen receptor pathway inhibitor, and docetaxel, whose disease has now progressed to metastatic castration-resistant prostate cancer?
Well, in this space, patients who are heavily pretreated with ADT and ARPI of 1 or even 2 and chemotherapy, generally with docetaxel. The recommendations are not new within the last year or two, and they include Pluvicto, a PARP inhibitor if HR positive and they haven't had one, second-line chemotherapy such as cabazitaxel. And if they're a very rare group and they've been sequenced and they're MSH high, then considering a PD-1 inhibitor such as pembrolizumab can be considered. I will note that this is a very small percentage of mCRPC patients, probably in the order of 5% or less.
Understood. And I appreciate you reviewing the recommendations across all of these patient populations. It sounds like some of the key points is that HR testing is very important for this patient population, and that the algorithms and the tables in the manuscript provide the full list of options that clinicians and patients can refer to.
Those are the highlights. And I will note in the tables, all the sections have a special consideration section because patients never fall into the black and white of one category. And those practical information or special situations sections of each of the recommendations can also help clinicians think about the individual patient in front of them and how they might choose one therapy over another, since there are generally choices in all of these treatment situations.
Absolutely. That information for the individualized patient clinician decision making is really key when, as you said, there's a list of options to choose from. So, in your view, what should clinicians know as they implement this living guideline update, and how do these changes impact patients?
I am so excited about this living document. ASCO has invested to developing the software to, in real time and iteratively, assess the new data that's published in prostate cancer and other diseases. So now we don't have to wait many years for the next guideline to come out. The guidelines will be updated every 6 months in prostate cancer based on this automatic search of the literature and a standing panel of both academic and community experts in prostate cancer treatment. So we no longer have to wait. That's what makes this guideline stand out to other guidelines. And in the digestible format that we've made, a clinician can seek out the table and read some details, seek out the practical information for the recommendations, or they can just go right to the clear figure algorithm and take a quick snapshot. Yep, I need to do HR testing, done. Oh, okay, HR positive or negative, these are my options. And then think about the individual patient in front of them when there's more than one option. For instance, a patient with cardiovascular history, abiraterone might not be a good choice for them, or a patient with neuropathy, docetaxel might not be a good choice for them. But within this guideline, it really will be up to date and focused on the busy clinician and knowing what the options are for their patient.
Definitely. This new era of living guidelines is very exciting and can provide even more up-to-date evidence-based recommendations to really support clinicians and patients with metastatic castration-resistant prostate cancer. So in that vein, finally, what is the panel examining and what are you excited for new data coming out for future updates to this living guideline?
The future updates will depend on the results of phase 3 clinical trials. There's many phase 3 trials ongoing in advanced prostate cancer, some of which include targeted therapy, which has been long awaited in prostate cancer. So such compounds as antibody drug conjugates that are targeting certain proteins in prostate cancer cells, such as STEAP1, KLK2, B7H3. So I think we're entering a new era in prostate cancer where we will be targeting cells and delivering drugs and applying them to prostate cancer if the trials are positive. So I think with AI and a large investment in prostate cancer clinical drug development, I think the treatment options for our patients will be rapidly evolving in a manner not previously seen. So the guidelines need to follow along with these developments.
Definitely. It sounds like an exciting time for research in metastatic castration-resistant prostate cancer, and we'll await the result of those phase 3 trials to inform this guideline and lead to future updates. So I want to thank you so much for your work to rapidly and continuously update these guidelines and for your time today, Dr. Taplin.
Oh, it was my pleasure. ASCO has been a leader in this area, and as a practicing clinician, we're thankful for the investment and guidance that ASCO gives us.
Absolutely. And finally, thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/genitourinary-cancer-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.